Good evening, everyone. Thank you very much for joining for this topic. Actually, Indu, I was thinking everybody will be interested in this topic. I am very much interested in this topic. I don't know. Anyway, so I today talk is on immunotherapy, and it's a review article. It's going to be presented by Dr. Revathy Sadasivam from E-Road, and it's going to be moderated by Dr. Radha Vembu from Chennai. So all of you know both of them. So we'll start. Dr. Radha, all yours.
Yeah. Good evening, everyone. I thank the Salem chapter and Dr. Vani for giving me this opportunity to be part of this journal club. And we all know that the field of reproductive immunology is gaining much attention, and probably the diagnostic testing and individualized medicine will be the future. And these experimental therapies are performed at the expense of the patient without knowing the clear-cut background. So it will be very nice to have a good knowledge at the end of this session, what is the evidence-based guidelines, what we are supposed to give, and when and how long we are supposed to continue. So I request Dr. Revathy to present the article.
Thank you, ma'am. Ma'am, are my slides visible?
Yeah.
Good evening, everybody. Warm regards from E-Road. In today's journal club session, we have an interesting article for presentation. It's about immunotherapy for recurrent pregnancy loss, a reappraisal. It's basically a review article. And this article was published in Fertility Sterility Journal, Jan 2022 edition, a relatively new one. And the authors are quite a big team of people from the Department of Allergy and Immunology from the McGill University and Montreal Hospital, Canada. And we have few authors from the Jeddah University, Saudi Arabia as well. This team has varied department people involved from the Department of Immunology, from the Department of Internal Medicine, from the Department of Fertility Medicine and Gynecology as well. Now, basically, this recurrent pregnancy loss is a condition which affects almost 3% of couples attempting to procreate, out of which 50% of cases remain unexplained, and the risk of repeat miscarriage following 3 miscarriages could be as high as 45%. Now, this article lays more importance and limelight on those couples experiencing unexplained recurrent pregnancy loss. Now, as we all have understood, immune system is quite intricately involved, not only in the initiation, but also in the maintenance of pregnancy. But as of now, there are no diagnostic validated testing techniques which are available to identify immune-mediated pregnancy loss. Now, immune-mediated reproductive failure is often suspected in any case with unexplained RPL. Now, we have quite a lot of choices when it comes to immunomodulatory drugs, which aim to suppress the immune system, but they are often used on speculation with very limited scientific evidence. Now, this article is basically trying to provide us with all the available currently available scientific evidences, the knowledge gap, which would help us to harmonize our clinical practice. And ultimately, it's given us certain practice recommendations as well about the various forms of immunomodulatory therapies available. We'll be discussing about progesterone therapy, low-dose aspirin, low molecular weight heparin, GCSF, HCG, steroids, intralipids, and finally about IV immunoglobulin. Now, immunomodulation for recurrent pregnancy loss is probably the most effective when individualized to the underlying immune-mediated defect. And ideally, it has to be started prior to the conception. Most of the time, our immunomodulatory therapy fails and it gives us disappointing results because we use it as a blanket therapy and we're not able to address the specific underlying immunological defect. Now, recurrent pregnancy loss in this article includes patients with 3 or more than 3 consecutive unexplained first trimester miscarriages. For a pregnancy to be successful, The maternal immune system must develop some sort of selective tolerance to this semi-allogenic fetus, but at the same time, the maternal immune system should retain or preserve the competence required against the antipathogen defense. So this is that intricate balance which is expected. Let's first talk about the progesterone therapy. As we all know, progesterone plays a very vital role in the establishment as well as in the maintenance of pregnancy. It has a crucial immunomodulatory role as well during the peri-implantation period as well as in the early pregnancy period. Provided with a very good safety profile and an excellent tolerability profile, it provides a good rationale for the exogenous progesterone supplementation in patients with recurrent miscarriages. The largest RCT published till date with regards to progesterone therapy, it has included 826 women with 3 consecutive miscarriages, but it did not find that vaginal micronized progesterone supplementation in early pregnancy improved the live birth rate. Now, the second largest RCT was by Kumarasamy et al., who reported that intravaginal micronized progesterone improved the live birth rate with 3 consecutive miscarriages. And these set of patients presented with repeated episodes of first trimester bleeding. And this was compared with the placebo. Ultimately, these two trials evaluated the administration of micronized progesterone after the conception phase, that's in the early pregnancy phase. However, progesterone's immunomodulatory effect begins before implantation. So for us to have the complete immunological benefit of progesterone therapy, ideally it should be started in the pre-conception period and not in the post-conception period, and that was the recommendation. Next, it's about the low-dose aspirin. Being relatively a simple drug, good ease of administration, good tolerability profile and safety profile made it a very attractive choice of immunomodulatory therapy in handling patients with recurrent miscarriages. Now, Shistaman et al. Performed an RCT evaluating the pre-conception low-dose aspirin therapy versus placebo, which included almost 1,000 women with 1 or 2 previous miscarriages, but he did not prove any significant improvement in the live birth rate when comparison was done with the placebo. Now, when a subgroup analysis was done, they found statistically significant improvement in the live birth rate, and this subgroup of people presented with elevated CRP. Now, CRP is basically an inflammatory marker which signifies systemic inflammation. So the recommendation goes like the pre-conception low-dose aspirin is likely to benefit women with elevated baseline CRP level. Now, next we'll talk about heparin therapy. Now, heparin in our prescription has become as common as a folic acid into our prescription. It's mainly because of its anti-inflammatory effect and pro-angiogenic properties. It aids to promote the trophoblastic invasion, mainly by promoting the endometrial vascularity, as well as it promotes or upregulates the endometrial expression of the adhesion receptors and the adhesion molecules, which are essential for a successful implantation. Now, we have 2 set of RCTs by Badaway et al. And Dolsky, but they showed no beneficial effects in women with 3 miscarriages, but these set of people tested APLA negative. So it's basically the unexplained RPL group. And then there was a comparative study which compared low-dose aspirin alone versus heparin alone versus low-dose aspirin and heparin combination therapy. But finally, they identified the low birth rate to be similar. There was no statistical difference between the 3 groups. And there was another subgroup analysis by Shaban et al. Who compared enoxaparin versus tinzaparin. We have very, very few and limited studies which usually compares the different formulation of low molecular weight heparin. There was a marginal improvement in the live birth rate and reduction in miscarriage rate in the tinzaparin group, but it was not scientifically, statistically well powered. Now, in keeping with the fact that endometrial immune and vascular remodeling begins right before implantation, the preconception or the periconception use of heparin may be more beneficial in patients with RPL rather than starting it in the post-implantation period. So the recommendation goes like LMWH can definitely be considered in women with 3 consecutive miscarriages, provided we rule out pre-existing thrombocytopenia, be it unfractionated heparin or low molecular weight heparin. This is based on the recent meta-analysis involving 1,083 RPL cases. Now let's talk about the combination therapy of low-dose aspirin and low molecular weight heparin. The basic concept is that RPL is caused by thrombosis and inflammation of the decidual vessels, and there is enhanced trophoblastic apoptosis. In vitro studies have clearly demonstrated that low-dose aspirin has the ability to bring down the oxidative stress-induced trophoblastic apoptosis. Now, heparin acts the other way, but still it increases the production of anti-apoptotic proteins. So ultimately, the trophoblastic apoptosis is halted, and that's how we expect some sort of beneficial effects. So in vitro studies have suggested that the combination therapy is expected to reverse the trophoblastic apoptosis and to improve the implantation rate as well as the live birth rate. But this had not been yet clinically substantiated, and the dosages are yet to be stratified for the combination therapy. Now let's talk about the other molecule. It's the granulocyte colony stimulating factor. Both GCSF and GM-CSF are actually produced by the secretory endometrium, which acts as a physiological stimulus for the leukocyte recruitment and indirectly promote the decidualization and the spiral artery remodeling. Now, GCSF, apart from this, also has an immunomodulatory effect to downregulate the uterine dendritic cell antigen presentation and to enhance the regulatory T cell differentiation. So basically, GCSF is a well-tolerated drug, and most of us have started using it regularly, except for the dose-dependent musculoskeletal pain, which is complained by few patients. Now, there was one article which showed that there was no clinical benefit with the intrauterine administration of GCSF. And Scarpellini et al. Was another person who randomized 68 patients to receive subcutaneous filgrastim right from the 6th day after ovulation till 9th week of pregnancy. And the live birth rate was clinically significant, but because the sample size was small, the results were not statistically significant and the study was underpowered. So with the available evidence, we cannot suggest or support the routine use of adjuvant GCSF for all patients with RPL. Let's talk about HCG. After implantation, syncytial trophoblast secretes increasing amount of HCG, and this maintains the progesterone secretion by the corpus luteum. And apart from this endocrine effect, HCG also exerts to some extent an immunomodulatory effect to modulate the endometrial immune cell phenotype, favoring the embryonic implantation. And it also induces tolerogenic dendritic cells and brings about selective recruitment and differentiation of the regulatory T cells towards the aspect of favorable implantation. But the available literature similarly does not support the widespread use of supplemental HCG, because with no available articles, HCG has been used as a standalone therapy. It was always clubbed with the other forms of immunomodulatory therapy. So we do not have statistically or clinically significant results with HCG usage to enhance the live birth rate. Next, let's discuss about corticosteroids. As we all know, corticosteroids, because of its broad anti-inflammatory effect and immunosuppressive activity, what we expect is that steroid administration will reverse all the immune abnormalities responsible for reproductive failure. But the basic physiology here has to be understood. Both decidualization and implantation are inflammatory and immune-driven processes. So steroid administration right before implantation would not benefit us, but in turn, it could give us a deleterious effect by bringing down the rate of implantation. Leukocytes are recruited to the endometrium after ovulation, and they differentiate locally to take upon certain pregnancy-specific functions like spiral artery remodeling and promoting trophoblastic invasion, recognizing the embryo. All these aspects need some sort of inflammatory response. That's what we all have understood, that even for a blastocyst implantation, there should be adequate inflammatory response as well. But the only thing is that the balance between the inflammatory and the anti-inflammatory response has to be intricately maintained. So pre-implantation steroid suppression of early immune event may actually impair the endometrial receptivity and the vascular adaptation process. In pregnancy, first trimester steroid exposure has been associated with a few side effects, like we are concerned about the cleft lip, cleft palate, the increased risk of GDM and gestational hypertension, to some extent preterm delivery and low birth weight. But if you're planning to administer corticosteroids, it has to be given at the lowest effective dosage, 20 milligram per day during the first trimester, and it has to be tapered once the patient has reached the point of a previous loss. However, there is insufficient evidence thus far that this approach improves the pregnancy outcome. So we are allowed to use this in a selective subset of patients. Next, let's talk about the fancy aspect, intralipid. Intralipid is basically a fat emulsion, which is composed of the soybean oil, egg phospholipid, and glycerin. It's basically a part of TPN that we've used in our internship days. Now, Darkley et al. Was the one who showed that live births were more frequent in the intralipid group when he compared it with the placebo control. And he conducted this trial on 192 patients with 3 consecutive miscarriages. And intralipid is expected to bring us a good clinical outcome by bringing down the elevated natural killer cell associated cytotoxicity. So it's expected to bring about some anti-inflammatory response. There was an increase in the live birth rate in the intralipid treated group when it was compared with the control group. But similarly, the flaw here was that more patients in the intralipid group also received other forms of adjuvant therapies like low-dose aspirin, low molecular weight heparin, and prednisolone 20 milligram a day. So as of now, we have insufficient evidence to regularly recommend the intralipid for all cases of unexplained RPL. But according to Darkley et al. Study, it was started prior to the implantation phase, and it was continued once in 3 weeks till the patient completed 12th week of gestation. Next, it's about the IV immunoglobulin therapy. It's basically extracted from the pool of sterilized plasma of thousands of healthy donors, predominantly with polyclonal immunoglobulin G. Now, IV immunoglobulin, initially we had so much of fear about this anaphylaxis, but all of us are quite now reassured that it's well tolerated during pregnancy. And the risk of adverse effects is quite minimum. The most commonly encountered adverse event is post-infusion headache, which could be handled by slowing down the rate of infusion and by promoting the pre-therapeutic hydration part of the patient. Very rarely we do encounter certain serious complications like acute thrombotic episodes, aseptic meningitis, and acute hemolysis. And Houghton et al. Performed a systematic review which included 7 RCTs with a total of 442 women with unexplained RPL. But this meta-analysis did not find IV immunoglobulin to significantly improve the live birth rate over the placebo control. But there is a specific subgroup of patients who are likely to be benefited with IV immunoglobulin therapy if it started in the preconception period. They are those patients who have miscarried 3 or more than 3 times with euploid pregnancies, and when other forms of previous immunomodulation therapies have failed. Yes, this set of patients are more likely to be benefited with IV immunoglobulin therapy. And other therapies which are not of much use nowadays is the lymphocyte immunization therapy, where isolating the lymphocytes from the male partner and injecting them into the potential mother to induce the immunological tolerance to the paternal antigen was once in practice. A dysfunctional immune response probably underlies the reproductive failure in a subset of, but the problem is with each patient, this dysfunctional immune mechanism, it varies. It's quite multiple. So the concept is that the broad immunomodulatory therapy, it cannot take care of all kinds of immunological deficit. And what we have to do is we have to address or customize to the specific underlying pathology. Now, coming to the conclusion, unfortunately, till date, immunomodulation therapy has given us only disappointing results. Most treatment recommendations are not evidence-based, and it's based on the expert opinion. Emerging data suggests that immunomodulation is very beneficial in patients with elevated natural killer cell count, with elevated cytotoxicity, increased T helper 1, helper 2 cell ratio. However, it's quite unclear because the peripheral blood immune picture will not actually mirror the endometrial immunological events. So even the validity of such testing is under question. A more recent and emerging approach involves the mid-luteal phase endometrial immunophenotyping, which will help us to assess if there is immunological overactivation or underactivation. And supposedly we can individualize the immunomodulatory therapy. So these are the ultimate practical recommendations according to this article. Progesterone therapy can be considered in patients with 2 miscarriages, and luteal phase supplementation is ideal. Low dose aspirin can be considered in women with 2 or even 1 miscarriage, provided the patient has an elevated baseline C-reactive protein level. And we need to make sure about the compliance of low dose aspirin with these set of patients. Low molecular weight heparin can be considered in patients with 3 or more than 3 miscarriages. And ideally, it has to be started in the preconception period. GCSF, as of now, do not have adequate evidence to regularly support or to suggest it as an adjuvant therapy. Similarly, HCG also doesn't have enough evidence to support, to recommend it as a regular adjuvant therapy to improve the live birth rate in RPL cases. But what they suggest is the pre-conception mid-luteal phase HCG is more likely to give us some sort of benefits. And glucocorticoids are ideally administered in the lowest effective dosage, 20 milligram per day, and it has to be tapered once we reach the point of the previous loss. But before initiating the steroids, we need to rule out the metabolic risk factors. Intralipid therapy, we do not have adequate evidence to support its regular usage. IV immunoglobulin therapy is likely to benefit patients with 3 or more than 3 miscarriages who have failed other forms of immunomodulatory therapy. So thank you. Thank you all so much for your patient listening.
Thank you, Dr. Revathy. It was a wonderful presentation. You have covered all the drugs which have been used in our day-to-day practice, even though many of us didn't know what is the evidence behind and what is the side effects and how to utilize it. So before we start the discussion, this article is focusing mainly on unexplained recurrent pregnancy loss. It is not considering those with APLA or any of those. So it is only unexplained recurrent pregnancy loss. So that is the reason why we have so much of confusion. Of course, in those cases with the APLA or the genetic factors, we have some clue like what we can do or what we cannot do. And in this, they have also said that unexplained recurrent pregnancy loss accounts for almost 50%. So that is something which is to be kept in mind, because all patients we screen only for APLA, and if it is negative, we think what we should do next. So that is one thing. And we also think that all these patients, we tend to evaluate and treat them thinking that it is immunomediated. And many of the literatures or the articles which have been taken in this, we are not able to get a clear conclusion, probably because they are either underpowered or it is not an RCT, or the study has taken only some parameters like pregnancy rate or clinical pregnancy rates or ongoing, but many of them have not included the live birth rate. And sometimes the sample size is not adequate, so they're not getting the statistical significance. So that is something about the studies which have been taken for analysis in the reappraisal in this case. Now, coming to the first and foremost, the definition. So should we all agree with more than or equal to 3 miscarriages as recurrent pregnancy loss? Because ESHRE, if you take ESHRE guidelines or even the RCOG, they say more than or equal to 2 recurrent pregnancy loss. So I just thought this should be taken into consideration, because in our day-to-day practice, if we say we will wait for 3 pregnancy losses, then will the patient wait till that time? Hello?
Yes, yes.
Yeah, am I audible? Yeah.
Yes.
Yeah, so I thought that is one thing which we should take into consideration in our day-to-day practice. So of late, many of them, even the ESHRE says we should take it as more than or equal to 2 recurrent pregnancy loss. That's the definition. And the next thing is the role of progesterone. So here, many of us have seen that in our infertility practice, we are using progesterone as an immunomodulator. And here there is a lacunae in this study. They have not taken into consideration the studies, what is the dose, the duration, and how long they have given when they have started. So probably that also varies, and the route of administration also matters. So that has not been taken into consideration when they have compared the studies, then reappraisal. That's what I felt. And probably another article which you said about Kumaraswamy's, where he said that it is beneficial in patients who have first trimester, who are bleeding. In those cases, it is beneficial. So we also did one study similarly, and we measured the level of progesterone. Even now in our IVF patients, when they come to us with bleeding, we measure their progesterone level. So normally on the day of transfer, we are measuring the progesterone. And again, 7 days after the transfer, we measure the progesterone. And we see that the progesterone levels are maintained more than 20. And in case a patient comes with bleeding, we are measuring the levels. So probably if we measure the progesterone levels in these cases, maybe it might be beneficial. Maybe the level has to be maintained beyond 20. That's what I felt. Anyone wants to add on that? Because that article specifically mentions that it is beneficial only in patients who have presented with bleeding.
Yeah, actually, I don't have an experience in measuring the progesterone when they are bleeding. I think many of the main thing which I found in this article is that if you are aiming to do any sort of immunotherapy, I think Revathy also pointed out, we have to start even before the
pregnancy
starts. So majority of the articles they could get were anything, progesterone or anything was started after she comes as pregnant, and then either low-dose aspirin or LMWH and everything. So that is why I think for everything they said.
Yeah, that is also one point which I thought I should discuss.
I think this article they have mentioned that, because in several other articles they will not mention that. They'll say it is not useful.
Yeah,
not saying why it is not useful, because it is not even studied properly. So they didn't have a proper study where it has started in the preconceptional period and then continued, and whether it worked or not. So that at least they mentioned that thing in this article. I thought nice.
Yeah, that is what one good thing about it. And and they have not mentioned, as you said, that when they have started it. If we correlate with our IVF patients, we are starting them in the luteal phase. Probably that is beneficial. But in this recurrent pregnancy loss, we don't know. Many of them may come with a spontaneous pregnancy also. So we may not be able to time the starting of progesterone in the luteal phase until and unless we are monitoring or documenting ovulation. So that may be one reason why they have not taken into consideration. I'm not sure. Maybe if it is a conception after ovulation induction, where they've documented ovulation and they've started the luteal phase, probably we can measure and we can take that into consideration. But why I said this was, we are doing that study. Maybe after some time we will be publishing that. Any patient who has presented to us, even if it's a spontaneous conception, we are measuring the progesterone levels when they come, and if the value is less than 20, then probably it is beneficial to start progesterone with them. That is what we have got in IVF cycles, or the FET cycles for that matter.
So if she comes with bleeding and you measure progesterone, if progesterone is more than 20, you don't supplement?
No, it may not be beneficial. There may be some other cause for that. Okay. That might be the one of the inference we can take. And again, in this, they have not mentioned, there is lacunae about when to start. They have not mentioned, and the route, of course. Now, if you are measuring the progesterone, there's another fallacy, because if you are giving the parenteral IM or subcutaneous, the values will be higher when rather than when we give in the vaginal route. So that is one of the things which we should take into consideration. Then they have also said, even though they have taken the definition as 3 miscarriages, but their recommendation for progesterone is if it is 2 or more miscarriages, it is better to start progesterone. So that is one thing about progesterone. And when I went through the other articles, they said when we compare, some of the studies have said that when the parenteral route, the pregnancy rates might be better, but vaginal, when we are administering, if it is administered properly, the endometrial levels of the progesterone is better and the side effects are also less. So the route of the administration preferred is a vaginal route. And one thing to be for the postgraduates, benefit of postgraduates, oral route is not advisable because of its own side effects and the first pass metabolism. So we don't recommend giving progesterone orally. That is one thing. Now coming to the low dose aspirin, yes, as you said, it has been commonly used as a folic acid supplement, similar to that. And one very good point which they have mentioned is about the CRP. That CRP is very important. We had a short study on that. One of our fellow did that study, but where we measured the CRP levels, and again on the day of starting the progesterone and 7 days later. And normally there will be some amount of elevation of PRP. If the values are very high on the day 7, we found that the number of miscarriages were more. So, but one fallacy with that, and one problem we faced was the lab to lab variability will be there, and the cutoff value. Usually they take 0.6 as a cutoff value, but it depends on the method, how they use it. So if we are measuring the CRP and if it is elevated, probably in those cases, low dose aspirin has a role. And the next thing is about heparin. Every one of us, are we using only low molecular weight heparin or even unfractionated? Anyone wants to add on that? Because we are using, for many of them, unfractionated heparin also. Dr. Revathy, you want to add something?
Over the past 4 years, we have totally moved to low molecular weight heparin, ma'am. So actually, after starting low molecular weight heparin, we stopped even screening that periodic platelet count as well.
Yeah,
so
because
here they have mentioned about platelet screening even for low molecular weight heparin. That's what.
Yeah, that is what was something which I wanted to know, because we are using both low molecular weight and unfractionated heparin because we have people from various strata. For unfractionated heparin, we are measuring the platelet count. But interestingly, this article mentions that you have to measure the platelet count even for low molecular weight heparin. I'm not sure about it because the mechanism of action is different. So that is something which is new in that.
Stop it by 36 weeks.
Yeah, we normally stop by 34, 36 weeks until and unless it is like APLA or positive or anything, we continue till 36 weeks. That is acceptable. But here, when they said about the platelet count to be monitored, that was something which is interesting. And here they are saying only after confirmation of pregnancy to start heparin. But if we correlate with our IVF patients, we do start them in the luteal phase. So is there any harm in these patients in case those pregnancies or after ovulation, induction, conception, probably can they start in the luteal phase itself? That is something which in their article also they have mentioned, probably if it is started before the pregnancy, it might be beneficial.
Conception must be much beneficial.
I think means I think a couple of years back, this big study, everybody started saying low molecular weight heparin is not useful at all. And I think they mentioned that study and said there the low molecular weight heparin was started after the FH was seen. So those people are anyway going to do better. So we cannot find any difference. So then they will not have any statistical difference.
Yeah, because even in our practice, recurrent pregnancy loss, we start have ecosprin or low dose aspirin. But after we check the FH only, we are giving heparin. Unlike in our IVF patients where we start. So can it be done in those patients also? That is what is.
I strongly think so, because that's what I think they mentioned also.
Yeah.
That if we want any kind of immunomodulation,
we should start
early. We have to start early. So I start early as soon as I see pregnancy, but without even confirming pregnancy, we don't know. Difficult unless in IVF pregnancies we don't start. But once we start seeing a small sac inside the uterus. Then I think we can start, and I do start.
Yeah, and because when we go through, there are some diagrams which have been given in this article, which is very useful for a postgraduate, where they have shown the mechanism, how it acts. So it is acting at the time of implantation itself. So probably after reviewing all this, we feel we can start heparin once the UPT is positive also, because we have been using in our IVF patients even before that. So there should not be any harm. Probably that should be a little change in our practice in patients with recurrent pregnancy loss. And regarding the combination of heparin and aspirin, that also they were saying that there is no benefit, probably because it was unexplained. I mean, the recurrent pregnancy loss where they have not taken the immunological reason, probably that was the reason where they found that it may not be useful. And one more thing they had mentioned in the article is about deltaparin also. Deltaparin is also being used in the dose of 5,000 units. So that is also being tried in addition to the other low molecular weight heparin. And the other thing is about the HCG. We have been using for our IVF patients, but for these patients, maybe in case HCG may be beneficial in case we suspect that the corpus luteum is not insufficiency. So it might help in maintaining the corpus luteum. So that might be one of the reason. But some of them, they have given 5,000 units weekly once or weekly twice. There are some articles. But how much is it's beneficial in improving the live birth rate is still questionable.
Here they are saying give it in the luteal phase, right, Revathy?
Yes, ma'am. Even for the fertile patients, fertile RPL patients, they've advised to give one shot of 5,000 units in the luteal phase.
Yeah, and they have continued also. After pregnancy also, they have continued. Maybe that taking over by the placenta, the luteo, the phase, till that maybe they wanted to support with the HCG. That is something. And the next thing which I wanted to get into notice is the corticosteroids. Here they are saying that if you are giving before implantation, it has got a deleterious effect. But after seeing that, I felt we are using for our IVF patients. Are we reducing their pregnancy rate because of that?
That was one thing I wanted to ask all the experts in the panel because we generally use it following the embryo transfer. But
because in this article they specifically mentioned that if you are using it in the before implantation, it is going to have a deleterious effect. That is why
I heard this statement by another person also, ma'am. If you remember Dr. Ramaraju,
I
think when he was talking in the Chennai conference or some other conference, he told it can be deleterious if you are not very careful.
So this article advises to start it in the the first trimester, early pregnancy.
See, actually, if you see in that diagrams, everything acts around the time of implantation. Around the time of implantation. So if at all you are starting, it should be in the luteal phase and the early phase. If you are starting it later, after there is some problem. See, there is no problem in having the implantation and the conception is there. But after that, it is not following because there is some factor. So probably all this should be started little earlier than what we are doing in our day-to-day practice. And one more thing, after seeing this, they have given, yes, we know all this, they have those congenital abnormalities and all that. Are we in this present era, should we take a written consent or should we document somewhere that these couple have been informed there is a risk of starting? Because if a child is born with a cleft lip or a cleft palate, are we can we be sued legally? That is something which is was striking my mind. Should we inform the couple before itself that we are starting just for the improvement of the having these abnormalities?
Actually, in this era, probably required, but very difficult, but to take
because
for each and every drug, because our list will be big and
yeah, that is what I was thinking. Now, suppose a child is born with a cleft lip or a palate, maybe due to some other reason, then are we liable? But and one thing he has told us to stop once it crosses the gestational age beyond the previous pregnancy loss. Say 7 or 8 weeks was the previous loss, we can stop probably after 8 weeks. Maybe that might be one thing. And the other drugs were like intralipid. We have been using this intralipid like a smoflipid, which is available for recurrent implantation failures. We have done a small study, but we found there is little improvement in the pregnancy rate. We have to follow it up to live birth rate. But one thing which we have to do is we have to measure the lipid profile. We have to assay the lipid profile before we start. That is something which we need to. Suppose already the lipid levels are very high, we are giving an infusion of lipid. So that I think we should be very careful. And I don't have any experience the use of IVIG. Maybe anyone is using it. I have not used it as such. And previously they were using this lymphocyte immunotherapy from the male partner so that the female partner is sensitized. But after that, the large the study in 2014, they stopped. They said that it may not be beneficial. And another thing which I wanted to highlight is they have mentioned about the peripheral markers and the uterine natural killer cells. So there were some studies where they were measuring the natural killer cells, and they were interpreting with the uterine environment. And they said that it is not going to be the same. And it is not that easy to measure the uterine natural killer cells. That is, so it is not being done nowadays. That's what I thought should be focused in this. So anyone else wants to add some comments on that?
Ma'am, what's your experience with this IM immunoglobulin, and how do you feel it helps in terms of live birth rate? Now, all discussion when it comes to our literature, it's with IV immunoglobulin. But in the current practice, maybe we have a lot of commercial formulations, this IM immunoglobulin.
No, I don't have any personal experience. We don't use immunoglobulins. We are using only this lipids, maybe in RIF patients, not for recurrent pregnancy loss. Okay. But intralipids we have tried, but the immunoglobulins have not used it.
I never heard of IM immunoglobulins, Revathy.
Yeah, IVIG only I remember, but maybe presently if it is there.
R-Globe is there, no, Bharat Seedham.
Oh,
IM.
Okay, that is also for recurrent pregnancy loss only.
It's for RPL. They don't promote it for RIF, it's for RPL. IM immunoglobulin from Bharat Seedham. I think there is one another brand as well. I don't remember what is the other brand, but Bharat Seedham is regularly giving it.
I never used it actually, but I know that a lot of people are using it.
I've seen a lot of people using it, and I've heard that it is quite beneficial. I just wanted to know if the mechanism, is it the same like IV immunoglobulin? Does this also act the same way? And the dosage should be the same.
Should be the same. Immunoglobulin should be the same. But maybe the side effects like the anaphylactic reactions, all that might be less.
Minimal, yes.
Yeah.
A lot of erratic clinicians from Kerala, they claim so because they say it gives almost similar clinical benefits, but still the risk of anaphylactic reactions are very minimal, and it's quite safe to use even in pregnancy. They say they even continue it till 27 weeks. I do not know if it's right or wrong, but I've heard from fellow clinicians, especially from Kerala, they use a lot.
Okay. Ultimately, whatever we are using, it may not be the ultimate thing. Should be a tender, loving care. Should also be added to this. I think that is also part of our agenda. So that plays very important role in addition to these medications, which we are trying to use it. But our aim should be not to cause any harm and use it as per the situation and individualize according to the patient's profile. That is what I felt.
I think the one more important point Revathy mentioned, I think we all know that it's an immunological event. The conception is an immunological event. We know that there is something wrong going on in that immunological event which is causing. But we have a lot of agents which suppresses this immunological response or something. But we don't have any tests to measure how much of suppression do we need, and what are all are there any different reactions which are happening, and what 1 2 3 what are not happening, and is there any way which we can tailor our therapy to allow the woman to accept this pregnancy. So I think this article briefly mentioned that we need there is a big lacuna, and we should be able to measure that. No, Revathy, I think that
yeah. And one more thing which was left out, because we are getting patients referred from outside, and we do it as a multidisciplinary approach. We involve the rheumatologist also. So they are using more and more of this HCQs.
Yeah.
HCQ and tacrolimus. I had a personal experience with HCQ. One of the patient, it was a single, first pregnancy only. Cardiac activity was fine at the third month. The NT scan, the cardiac activity disappeared. So I tried managing medically, and she expelled. And after that, she came with a typical CVT like symptoms. So everyone said that it might be due to infection, and that has caused this problem. So I took her for a check curettage, and immediately her eyes, everything was swollen on the table. And it was such a difficult situation to think about it, for a first pregnancy with no family history. Then after that, we started her on steroids and heparin and everything, and settled. Then second pregnancy, I took a hematologist's opinion, and they said, okay, we will go with a therapeutic dose of heparin. Again, she had a miscarriage. Then the third time I said, no, there is some problem. Then I sent her to rheumatologist. They did the detailed analysis, and then they found that lupus, so many factors were positive. They put her on HCQ. One problem with HCQ is they have to be evaluated every 6 months because it has an effect on the retina. Retinopathies are common. So after they started all this HCQ and all our heparin, Cosprin, everything was there. And then she had again at 32 weeks, had to deliver her preterm delivery because Doppler changes were there. So HCQ is picking up, and we cannot use it judiciously, probably with suggestion from the rheumatologist, probably we can utilize that. That is also something which we should keep in mind. Maybe multidisciplinary approach would be beneficial.
Yeah. Aspirin and HCQ, actually, once we get their opinion, we can start in the preconception period.
Yeah. That has to be continued during pregnancy.
Yeah.
Any minimum pre-treatment period, ma'am, for this HCQS to act, like a priming medication? Do we have to put them on for a minimum of 90 days or 100 days, or is it like
they measure the levels based on they measure those complementary factors and all that. Till that levels are getting settled, they say to avoid pregnancy. So 3 to 6 months gap they give. And then they taper the medicine, some of them, and then they tell you can go ahead with the pregnancy. We cannot start immediately, but at the same time, they have to be, we have to look for the other side effects like the retinal changes and all that. So every 6 months, they recommend for an off-tal checkup.
What is the dose they recommend generally?
Twice daily, 100 mg, twice daily, I think so. I'm not sure. It must be 100 mg twice daily. So that is also something which we should keep in mind. Maybe we cannot start it, but we can take their opinion and then we can go.
Any personal experience with this tacrolimus, ma'am? Because I saw a few articles, not in this, but generally they have started talking about tacrolimus as well.
No, immunosuppressants, they use the renal transplant patients and all that. Only those, we have not many patients, maybe 1 or 2 which they have come, but not for RPL. Post-renal transplant like that, they have come.
I think 4 or 5 losses and unexplained and all that, I think they've tried, and even I read the article. Even I don't have a personal experience. I believe it's a safe drug to use when we, she keeps on rejecting. That is when I think they might use. Anybody else has any personal experience with these drugs or want to discuss? Please unmute and talk. Indu, Selvi. Aishwarya.
Hello, ma'am. This is Dr. Aishwarya.
Yeah. Hi.
Hi, ma'am. Ma'am, I have a patient. I have a query. Can I ask?
Yeah, sure.
Yeah, sure.
Okay, ma'am. This lady had she already has a child, and she had come with 2 pregnancy losses. One was a documented miscarriage, and another was a blighted ovum. So this time, I had done all the evaluation. The usual APLA and thyroid antibodies, everything was negative. Cavity scan, everything was negative, normal. And I asked her to conceive and then put her on luteal phase progesterone, luteal phase ecosprin, and asked her to come back. Again, this time she had a miscarriage. Like she has a live birth, and this is her 3rd time she's having a blighted ovum.
Maybe a secondary RPL like picture.
So what would be the next best management?
See, here we have not thoroughly evaluated all the other causes, right? We have done only APLA and maybe the uterine factor you have ruled out.
Yes.
There are other factors also, right? Like in case there is any lupus or any of those factors that also have to be worked up. But blighted ovum, no idea. Maybe.
There is a condition where the first pregnancy does some kind of sensitization and causes this kind of immunological problem in the uterus. So they'll have one live birth, and after that continuous
miscarriages.
Yeah, it's rare, but it can happen. It is triggered, this kind of immunological response is triggered by the first pregnancy. And again, we have to do a lot of immunotherapy. There is no, I don't think there are so many cases reported that anybody could do a study to say, use this in so much dosage. You just have to very cautiously up your immunological therapy. Add one by one, and then probably add HCQ also, and steroids, and there is. That's what that this study is saying. There is a big lacune that we should be able to do some test to find out this immunological defect and treat it appropriately. But we don't have those tests, but we know that there is something going wrong. So this particular condition is there. Even I have seen in a couple of my patients, and I just increased this immunological agents, and then could manage to go to a reasonable level where we can deliver.
And one more thing is, I just wanted to know what was the age of the patient when she conceived previously and now?
Now she's 32. Her last childbirth was 5 years back.
5 years back. Probably, maybe you have started heparin also in that case, I presume. And the low dose of steroid.
I thought I'll start it after seeing.
Yeah, that is. No, that is what we are discussing. We can start before also. Maybe you try.
Maybe next time I'll try. This was the take-home point. Thank you, madam. Thank you. And ma'am, Vani ma'am, thank you so much. Actually, last week I discussed the case about 8 biochemical pregnancy. So I have sent her for a extensive genetic evaluation by a special geneticist at Hyderabad. So they would come back with some results. I'll discuss it in the upcoming journal club.
Please keep us posted.
Okay. Thank you.
You seem to have a RPL clinic?
No.
8 classes, 4 classes, 5 classes.
Yes, ma'am. I had one more patient with 8 previous missed miscarriages. And there was a study which supported her genetic test. And there was a new mutation that was found in her. Everything else was normal. So we changed the gamete. We did a donor IVF cycle for her, but it turned out to be negative. After that, she hasn't come back. So next time, maybe we should add some rheumatologic factor as well and consider and maybe treat her, ma'am. So
You-
that is also another case I have. The three
Donor gamete is a sperm or a oocyte?
donor oocyte.
Yes.
Anyone else has anything, any personal experience?
Ma'am,
Sethi?
I have a doubt, ma'am.
Yeah.
I'm Dr. Ramya
Yeah.
from Europe, ma'am. Actually, one patient came with a history of 2 missed miscarriages. At around 7 to 8 weeks, there is absent heartbeat, ma'am. For the third cycle, she came to me and I just gave her oral ovulagens, and with the timed intercourse, she conceived naturally. And since she had a history of 2 missed miscarriage, I already ordered for APLA ANA testing, and in that ANA came to be positive. And we got a rheumatologist opinion and started on aspirin, HCQ, and folic acid. And once she became pregnant naturally, after UPT is confirmed, then we started on heparin also. But still, this time also, it's a miscarriage, ma'am. At around 5 to 6 weeks, there was appeared to be a cardiac flicker, but at 7 weeks, there is no further growth, ma'am.
Probably she needs to be worked up fully for other causes also. Genetic problem, karyotyping.
Genetic karyotyping is both a couple normal, ma'am, and TSH and GTT, everything is normal.
Okay.
HbA1c is also normal.
Okay. Maybe the rheumatologist may have to do some extensive evaluation.
Yeah, SLE,
and then
detailed SLE profile also we did, ma'am. That is all negative. Only ANA nuclear pattern is positive. Full SLE profile is negative only.
Okay.
Aspirin only we started on 75 milligram. Is it it will cause difference if we increase to 150 milligrams, ma'am?
In those cases, some of them they recommend 150.
Okay, ma'am.
150 also they have recommended.
Immunological therapy can we try in this patient, ma'am?
Which one?
Immunological therapy we were discussing, no, ma'am?
No, we can try, but how far it will be beneficial, we don't know the cause exactly still.
Should I do the torch?
It's just
panel,
a trial
ma'am?
and error. Torch is only for that pregnancy. It's not going to be applicable for the next.
Yes, ma'am. It's not recommended one.
It's not recommended.
Products of conception you can send for genetic.
Yes, ma'am. Yes. That also I have sent this time. It came to be normal only, ma'am. There is no genetic thing.
So then.
Okay, and one more thing, what we some of the literature says is even chronic endometritis, even though it is associated with RIF, it is also known to have its role in RPL.
Okay, ma'am.
So you can maybe how much it will pick up, I don't know, but you can do it and take a sample and send it for workup of the chronic endometritis. That is also studies have shown it's also there with RPL.
She's having a problem of thin endometrium, ma'am. Whenever we prepare the endometrium, she used to have only 4 to 5 millimeters endometrium.
Yeah,
maybe have you done?
Yes, ma'am. I have not done any biopsy, ma'am.
You should do a hysteroscopy guided biopsy.
Okay, ma'am.
I think from our side we can do that instead of going to a rheumatologist and asking their help. From our side, I think we should do that. Maybe if you have this one for a workup of chronic endometritis like CD138, because plasma cell identification is little difficult. All pathologists may not be able to do it.
Okay,
so
ma'am.
you can send it for CD138 workup also.
Okay.
So
CD138, ma'am.
Yeah.
That is enough, ma'am.
Yeah, they along with plasma cell they do with histopathology. Okay, and CD138 that is more precise. It can pick up.
Okay, ma'am.
Okay, and you are supposed to take the biopsy preferably in the follicular phase from day 7 to day 10, day 12 maximum, not beyond that, because once the endometrium becomes thick, they cannot identify the plasma cells.
Okay, ma'am.
So probably I think you should do that also. Hysteroscopy.
Early follicular phase. Okay.
Yeah, hysteroscopy guided biopsy, and there may be some features of chronic endometritis even on hysteroscopy, like mucosal edema or micropolyps, anything of that sort. That also can give you a clue. And one more thing, you're saying she's having a thin endometrium. That is also one reason for that.
Okay. Okay, ma'am.
Madam, this is Selvi. I just wanted to ask Radha ma'am, like I just have a patient around 35 years. She's with me for the past 5 years. I've done 5. She's a known patient of bilateral serous acanthoma. So she'll never ovulate and it'll be like a pearly ovaries. So we've done a laparoscopy, we've done a hysteroscopy. So she doesn't have that ovulating potential because every time it'll be blown up like cyst. So we went in for donor oocyte and husband's sperm. We did 2 cycles of that. It went in for missed abortion. So totally, I've done 5 transfers for her. Then finally, the third one we switched on to embryo donation, and that also like out of 5 cycles, I think from the third cycle we did get pregnancy. We did see the sac, but after probably exactly that 7 to 8 transformation, just a flicker of FH, then the next week it will not be there. Repeat hysteroscopy we have done. We've given heparin prior to this. The only thing I've not done is giving that HCQ. I had not tried. Even the low dose steroid we've tried.
No, you have done the workup of all the other immunological workup.
Immunological completely normal, madam. Because when we came to know it is an acanthoma, we just did the SLE and all the Tapla and thyroid. Everything is normal. So we don't know what to do next for her. So we did day 3 also we've done blast also, sequential also. This time we've done sequential also, but exactly that 6 to 7 will get a value of 1500 beta HCG, then it will double up and everything. But that one flicker of FH at 7 weeks, and the next week you call her, it is not there.
Probably you should have a rheumatologist workup also. She may require other medications.
What we have not done, is that HCQ I have not tried it with her, but I don't know what. Probably that might help, or I don't know, doing 5 cycles with her. It's really, you don't know what to speak to her. She knows IVF more than me now. We've done ERA also, thinking that probably we're not matching the implantation. ERA is also done.
ERA may not have a role because she's conceiving and cardiac activity is appearing. So ERA may not have a role here.
We just thought, okay, probably. But one thing is, as the time is progressing, now she's responding this cycle. We did it only with natural cycle. We were not able to get the endometrium with the HRT. And she started getting all those cysts recurrently. So we have to do a oophorectomy 8 months back during the COVID period. Every time she'll come up with one cyst there. So E2 will be around 130, 150 or 200. So you can never bring her down regulation to that level. So that landed up with oophorectomy one side. She's got one ovary now, but she just gets
TSH
that 6
is normal.
to 7 weeks.
TSH is normal?
Normal, madam.
Okay, because they share that one unit. FSH and TSH, they share, no? So some people, they can present like that. That is one thing.
TSH is normal because before transfer, we see that and because we know pretty well that she's very high risk thing. We know her from the beginning, seeing her thing, but HCQs have not tried. I don't know how far this is going to do, but anything else, we've done everything, hysteroscopic biopsy, everything is done, everything is coming normal. So I don't know what is
something like this HCQ or something maybe you can have a rheumatologist opinion, and after that you can start. Once they give this one clearance, then you can
because I've just started heparin after the transfer. I don't wait for the cardiac activity also. I just try anything to make her thing, because after seeing the second miscarriage, then it's like that. But only HCQ probably.
Because you are saying about embryo transfer, we start heparin post embryo transfer itself. We don't wait for the pregnancy.
Yeah, that's what, madam. I don't wait for all patients.
Even
I don't
the luteal phase we start.
Yeah, we start from the day of thing. So those factors, whatever we're discussing, it's already been corrected and it's been put in place. So I don't know.
Because one of the additional point which I learned when we were treating the patient, which I told you, the second time we started with heparin, low molecular weight, and we have to check the BMI also. In more than 60, they tell us to start. If you are starting with 0.4 of Clexane, you have to increase it to 0.6. That dose also might vary. The BMI also has to be taken to.
She's around just 60 kg, madam, not more than, because we keep the weight also around 60. She's a little bit that way only. She doesn't cross 60, 61.
Maybe you can have an opinion from them, the rheumatologist, and then start it.
Start the thing.
Yeah.
Any other dictum, like just to tell her, like, because she's very educative, like now?
No, we cannot say this is the reason. No, it's almost like an unexplained RPL.
explained.
I mean, yeah, because it's not a RIF, rather, it's a pregnancy losses. So,
Losses.
yeah, unexplained, it's only, these are all the empirical treatments only. We cannot say this is going to be beneficial. Maybe intralipid, if there is no contraindication. We are finding little beneficial results. So patients with RIF or pregnancy losses, we are giving intralipids. We found, but we are not published as such. We need some more data, but we find it is beneficial.
How do you give it, madam? Like, what is probably the thing?
We are giving it on the day of, we are giving SMOF lipid. We are giving it on the, even before embryo transfer or on the day of transfer. And 3 weeks later, maybe the first scan when you are doing for the cardiac activity. And at 10 weeks, 3 doses we are giving.
Okay.
SMOF lipid. I'm not talking about the intralipid. There's slight variation in the composition. So we are giving 3 doses there, either before or on the day of transfer. Day 11 also you can give. Then once the pregnancy is confirmed, at least 3 weeks gap should be there between the doses.
Okay. Immunoglobulins, I've not given
No,
out.
I
just
don't
thought
have
this
experience
cycle.
about
I don't want to.
immunoglobulin.
I don't know cost 5 seconds to big thing. I don't have anything to speak to her. So,
Just to take one opinion, I think, before you proceed with the other.
okay, man. Hope she comes
Yeah.
back this time. She was
Yeah.
literally.
And the other thing you should rule out is you can, if you have good embryos, grow for a blast and a PGT. Maybe the embryo factor also is there.
That's
That
what,
also you
madam.
should
We
see.
just thought, like, because PGT, I thought, okay, this is an indication for her to get it done.
Yeah,
So we
it
thought
is.
that
It
one
is
thing is
recommended.
remaining. Okay. Thank you, madam.
Anybody else has anything to say, or Kalai? Okay. So if we don't have any further discussion, I think we'll wind up. Thank
Yes.
you.
Thank you very much for the opportunity. Thank you.
Thank you very much for joining us in spite of your bad health. Thank you, Revathy. Thank you, everyone, for joining, and thank you for a lively discussion.
Thank you.
Good night, everyone.
Thank you.
Thank you. Bye.